Hello, everyone. I am pleased to invite our renowned faculty from America for this session on the CME, International CME on acute coronary syndrome. And introductory comments from me. Let me share the screen. Okay. When we talk of acute coronary syndrome, we need to have a look at what is the preponderance and significance of acute coronary syndrome in the community. 48% of all cardiac deaths are due to acute coronary syndrome. And that's why it's very important to understand the whole mechanism and to develop a situation where we can educate the people also to understand this whole scenario, which is very dangerous. In America, 1.57 million people every year get admitted with ACS. Out of that, 1.24 million are either an unstable angina or an STEMI, and 0.33 million with STEMI. When it comes to India figure, we have a projected figure extrapolated from the Kerala state, and we have almost 30 lakh MI STEMI in 1 year, 30 lakh, which is almost 10 times, whereas the population difference is 3.5 times. America's population is 3.5 times less, and we have 30 lakhs cases per year of STEMI. So it comes to, if we extrapolate to this overall acute coronary syndrome, then it comes to 15.7 million cases in India, and maybe 12.4 million of them are in STEMI. So it's a huge burden, socioeconomic burden on the country. The main cause for the acute coronary syndrome is development of the atherosclerosis with age, and so many other factors. Of course, we have multifactorial it is, and some of the factors like LDL is incriminated to the maximum level. Now we have a situation, either it can cause a plaque and can cause a stable narrowing, or it can cause a platelet aggregation on the plaque and produce unstable angina, or it can cause a non-occlusive thrombotic lesion and produce STEMI, or a completely occlusive thrombotic lesion and produce STEMI. So this is basically the full spectrum of the atherosclerotic coronary artery disease. On the other side, atherosclerosis, one side can produce plaque and narrowing, and other side it can produce the ectasia or aneurysm. And if you see the overall angiogram, 1.5 to 8% of angiogram will have ectasia, whereas the multiple cell disease and other things will be almost 50%. In the unstable angina, presentation is non-occlusive thrombus, no specific changes, normal enzymes. Enzymes slightly elevated, no ST elevation, only ST depression in STEMI, and ST elevation MI or LBBB, new LBBB in STEMI. Now, important thing to understand is the time after the onset of the chest pain to balloon to so door to balloon needle time and door to balloon time, both are very important. And as you go forward, and after 12 hours, no benefit as such. 6 to 12 hours, there is potential infarct healing benefit, but the maximum benefit is within 1 hour or 30 minutes. Our golden time, what we call, is 90 minutes. Door to needle time is 30 minutes, that is thrombolysis time. As early as possible, patient should be thrombolized if he reaches the non-PCI capable center. But if he has access to PCI capable center, then 90 minutes is the door to balloon time. That is when we can have maximum benefit in terms of mortality and overall survival. So this is something which is very important, and STEMI STEMI will present as ST elevation and increase in the troponin I and T levels. Similarly, in the STEMI, we will see as minor ST changes, and proximal LAD critical lesion, 2 millimeter deep T-wave inversion is good enough to guide us that this could be a Valence syndrome, where disease, if get occluded, can lead to what you call widowmaker syndrome. So this is the picture that we have. And we need to, when you have an STEMI, we need to calculate the risk to decide whether invasive strategy or a defer invasive strategy will work with, or invasive strategy within 24 hours or before discharge of the index admission. Then there is a gray score, and how this has come to a knowledge that when we did a TIMAC study.
Dr. Bang?
Hello?
We're unable to see your slides, sir.
You are unable to see my slides?
Yes, sir.
Can you see my slide now?
No.
No?
Please share screen again.
Share the screen again, okay. Let me try. I don't see a taskbar here. Taskbar is missing. And now I got the taskbar. Sorry to see that. Anyway, now, so what I was saying is, now since I can't see my slides, I might as well talk without the slide. And I don't know what has exactly happened, but let me conclude about my talk, that either if it is STEMI, either we have a 30-minute door to needle time to benefit the patient maximum with thrombolysis. If it is STEMI with the PCI capable center, within 90 minutes golden time, we should go have a PAMI. In STEMI, we look at the gray score or TIMI score. If they are high enough, then cath the patient within 24 hours. Median time is 14 hours. If this is not available for some reason, PCI capable center, then treat this patient medically and transfer them to PCI medical center, PCI capable center. So this is how we can look at the whole thing. Now, may I invite the next speaker? The first speaker was Daggubati, Dr. Daggubati, but he is not available. He will come a little late. He has an emergency to do. So I'm inviting Dr. Perwaiz Meraj to talk on his topic. Dr. Perwaiz Meraj is the Chief CTO Director at the Northwell Health in New York, America. And he's going to enlighten us on LTB management in STEMI, that is large thrombus burden management in STEMI. This particular class has a 90% mortality if not treated properly. So that's why it is very important that we understand how to treat large thrombus burden in STEMI. Perwaiz, may I invite you to?
Dr. Meraj, we can't hear you.
Can you hear me now?
Yes.
Now, yes.
Perfect. Well, thank you very much for the invitation, and to my esteemed panelists. It's a privilege to be here, and those who are listening in India, thank you for joining us. I think it's only appropriate that we start with a case, and I'll start with this case, which is an exaggerated example of what I would consider to be extremely large thrombus burden, and potentially even an embolic distal embolization of a large, plug of thrombus in the RCA. As you can see here, that travel down to the distal bifurcation. And you can see here the final result is it looked pretty good at the end. And so the question becomes is how do you get from the left screen to the right screen? And so we have a lot of options, and these options exist. We'll go through a couple of options. One is the use of intracoronary lytics, the use of intracoronary glycoprotein 2B3 inhibitors, use of vasodilators, the use of thrombectomy catheters where you actually manually or mechanically aspirate thrombus, or you just say, you know what, I'm never going to get this out. Let's just call it a day, and let's hope that time just gets rid of this thrombus. So just to review very quickly, my teacher and former mentor, Dr. Gibson, came up with this thrombus classification, grade 0, 1, 2, 3, 4, and 5. And as you can see here, really grade 0 is no thrombus present, and grade 5 is unable to assess the thrombus burden because the vessel is totally occluded. And that very commonly happens in many of our STEMI cases where you're unable to really assess the actual vessel because the thrombus is completely occlusive of the distal vessel. This particular thrombus probably falls in the category of 4 because it's very much almost the same size as the vessel. However, there was some contrast flow around that thrombus. So the solution, is it really thrombectomy? So for years, that's what we were thinking. Simple thrombectomy, use an aspiration catheter, put some suction with a syringe at the back end of it, and you're able to remove the thrombus. How about mechanical thrombectomy? Well, prior to the manual aspiration catheters, many folks were using, before my time, the rheolytic or angiojet thrombectomy catheters, all of which fell out of favor after the AMI trial, but we'll talk about more of this. And then obviously the use of drugs, 2B3 inhibitors and lytics, and I think this is very important to have that conversation. So clinical trials with manual aspiration, as we know, are utilized in the following trials: TAPIS, TASTE, and TOTAL. TAPIS was the original trial, as you can see here, which really showed the mortality benefit of thrombus aspiration as compared to conventional PCI out to almost over a year. And you can see here that there was a clear benefit in this particular trial to thrombectomy catheters. And this is what really launched the use of thrombectomy catheters more ubiquitously. The case study, slightly different outcome. As you can see here, they all cause mortality at 30 days, which is really where we're looking at the mortality and the benefit and the difference of thrombectomy in the acute phase and the acute setting of the patient's MI. You can see here that PCI plus thrombectomy versus PCI, albeit there was a decrease in all-cause death, there was really no significant difference. And you can see here that the effect of thrombectomy at 1 year, there was a large effect size in the TAPIS trial, but really no difference in taste. And the TASTE trial was about 7 times larger than TAPIS. It was also not a single center trial. And so therefore, many people have really fallen out of favor for routine thrombectomy. And as in the United States guidelines, especially, it's been taken away as a class 1 indication. If you look here, the primary outcome to cardiovascular death, MI, shock, or heart failure at 1 year, PCI alone versus thrombectomy, you can see really the curves completely joined. It looks like one curve. So really no difference between the two. And the one harm potential that was discussed in the total trial was that there may be a risk of strokes, albeit clinically, most of us who perform these procedures have really, honestly, I've never seen one. It doesn't mean it can't happen. However, and in the particular study, obviously, they were looking at it more closely. PCI alone versus thrombectomy, the stroke rate was almost double. And you can see here that there was a very significant difference in strokes if you use thrombectomy catheters versus you didn't, which is really the reason why it became a class 3 recommendation for routine use of manual aspiration thrombectomy in the US guidelines. So these were the clinical trials, TAPIS, TASTE, and TOTAL. As you can see here, these are the summaries. And really, today, we would normally say that traditional, typical, routine use of manual aspiration thrombectomy has really fallen out of favor due to the lack of benefit with the potential risk of harm. And I think that's the best way to describe it. There's only one study that really showed some benefit, and that one study is really standing alone. So how about in thrombus aspiration in high thrombus burden patients? That's really what we're looking at here. So there may be potential for more definitive thrombus aspiration in this particular subgroup. This was not specifically studied in just high thrombus burden or large thrombus burden. And if you look at this meta-analysis that was done by Dr. Bhatt and others, you can see here that aspiration thrombectomy is not associated with any clinical benefit, and you can see here that the concomitant administration of 2B3 inhibitors did not really influence potential benefits as well. And so this is really an interesting consensus for both thrombectomy and the use of 2B3 inhibitors. And if you look at the routine use of thrombectomy in this particular meta-analysis, you can see here pretty much across the board that all the trials pretty much cross the unity line. So really no benefit across the board. And if you look at stroke, there was a slight direction towards more strokes, but I would say that the overall picture, because of the statistics, don't really pan out. So as we said, in the ACC guidelines, you can see the usefulness of selective and bailout aspiration still exists in selected cases, and I think this is a very important point that we should remember, that in selective cases, this is a very useful technique. However, routine use is not really recommended. There are some new aspiration devices out there, which I felt like it was important to discuss. The Penumbra device, which is a aspiration catheter that's actually sort of not mechanical, but it is a suction, continuous vacuum suction pump. It's got a nice stiff catheter, and it actually works very well. There really is no data out for this yet, so we really don't know whether this is any better than the other devices. However, from an anecdotal standpoint, this does seem to work pretty well. There's actually a function control switch, so you're able to actually turn on and off the device at your fingertips. And you'll see here, this is exactly how the catheter looks as it goes down in our particular case. And so you can see here that is also the old school rheolytic thrombectomy catheter, as you can see here, and that this actually mechanically was supposed to break up the thrombus. It's been used in obviously the periphery and other areas very successfully. When it was attempted to be used in the coronary bed, however, unfortunately due to the AMI trial, you can see here that there really was no significant benefit versus angiojet versus control in terms of ST segment resolution. On the contrary, actually it was worse, and the infarct size reduction really wasn't that much better either. And if you look at this, and this is really where it fell out of favor, as you can see here, the difference between death and overall MACE events was very significantly not in angiojet's favor. And this really just took angiojet out of the picture and equation in terms of utilizing it in thrombus burden. Some folks have also used laser catheters, excimer laser catheters. It's an excimer laser energy. It's absorbed by the thrombus. It sort of liquefies the thrombus burden and ablates the underlying plaque. And in doing so, there may be some inhibition of also platelet aggregation in this process. It has not really been looked at specifically in any kind of randomized fashion for large thrombus burden or thrombus burden in general in STEMIs. However, it is something that is used selectively, and it's something that's interesting that I think future trials may be interesting in this particular space. The Carmel registry was really the only registry trial, no randomized trial, that looked at this. And you can see here that there was very good success rate with good TIMI flow resolution with minimal complication risk. And so it has potential, but we don't have any randomized data to looking at this. Local intralesional 2B3 inhibitors obviously have been looked at in conceptually and scientifically rationale. It was the INFUSE AMI trial that really provided the supporting data with the use of specifically local intralesional, not through the guide, dispersion of the 2B3 inhibitor in the actual vessel. The IDA trial disputes some of the benefits of the approach, and maybe there's another strategy. So if you look here, that you can see here that in the guidelines, it's still pretty much a 2A level of evidence across the board for all the different 2B3 inhibitors in the use of in the setting of STEMI. And I had done a Twitter poll to see how many folks out on Twitter actually use 2B3 inhibitors, and you can see here that pretty much across the board, I'd say it was less than 10% or less. So it was the majority of folks are not even not using it, and I think that's pretty much the routine. The INFUSE AMI trial, like I said, uses a specific catheter called a clearway catheter to actually deliver the drug, and an export catheter to remove the thrombus. It was a 2x2 design trial, and that's just the local delivery of the drug, which I think is an important piece of information. If you look at the outcomes of the trial, you can see here that infarct size. If you look at epciximab versus no epciximab versus aspiration versus no aspiration, really the aspiration arm didn't really show any benefit, but the epciximab arm did show some benefit. So really, it was more the 2B3 inhibitor that actually improved the outcomes. If you look at the different outcome events here, not to belabor the point, but you can see here clearly that there is definitely a benefit in the infarct size reduction in both the use of 2B3 inhibitors in these two outcomes. 1-year death also better in those patients who received any treatment versus no treatment, and I think that's an important piece of information. So I think this is a using eptifibatide and dose strategy and undergoing PCI. You can see here that they were treated with a bolus infusion. That was decided because it was determined whether that a bolus-only infusion of eptifibatide potentially reducing bleeding, reducing the need for transfusion. But unfortunately, there was really no difference in mortality or MI rates. So I think that, this is another thing that we use as a bailout technique in patients who have large thrombus burden and those who we don't get a great outcome on its own. And I think this is a good discussion. I think that this sentence, I think, is a key sentence from this particular paper, looking at, you really want to minimize bleeding in those patients by shortening the 2B3 infusion time, dose adjustments of heparin and 2B3As, careful access site management, use of transradial approach, smaller sheaths, and identification of high bleeding risk patients. Essentially, to summarize that statement, use it selectively and be very careful in the patients that you use it in. And in the right patient, it could be proven to be very useful. And I think that, don't use it in high bleeding risk patients, and really to reduce the risk of bleeding. This is the summary. So in conclusion, thrombectomy may not work, and really, unfortunately, we have 2 large trials that pretty much show no clinical significant difference between the two. With selective use in the right patient population, such as this particular topic of large thrombus burden, as the case I showed you originally, I think it's very reasonable and very appropriate to do it in that particular scenario. The goal is to reduce distal embolization and to preserve TIMI3 flow and a good blush score in that STEMI that we're performing. That is the outcome, because of those patients who do not have a good who do not have TIMI3 flow at the end of the case and do not have a good blush score at the end of the case, their outcomes are very poor in general. And obviously laser can be useful in certain cases, but not routinely. So sort of an overview of the different options we have in large thrombus burden. There is no one size fits all. There is no cookie cutter approach to this. I think it's very important that we selectively look at both the patient and the angiogram and collectively decide what the best approach to these patients will be. Thank you very much.
Thank you very much, Perwaiz. It was excellent talk, and you covered virtually everything. And we'll take questions and answer at the end. I think I see Ramesh come in the picture now. So let's invite Ramesh so that, Ramesh, Dr. Ramesh Daggubati is a renowned interventional cardiologist from America. He's Associate Chief of Cardiology at the West Virginia University. And may I invite Perwaiz Daggubati to kindly come forward and deliver his talk on ACS in coronary ectasia.
So thank you very much, Dr. Bang, and it's great to see Dr. Jauhar and Perwaiz and Prashant on the line. And did you notice, Rajiv, I addressed you by your last name?
I also like the fact that you have wearing glasses today. I like that.
Yeah. So I think you can see my screen now, right?
Yeah, we can see your screen slide and we can see you also.
Okay, thank you very much. So I'll show you a patient of ours. I think more than I'll describe it to you. I don't have any disclosures on this presentation. This is an 18-year-old young kid who comes into the hospital with chest pain and ruled in for non-ST elevation MI, and he was taken to the cath lab. And you see here, these are more than ectasia, and show you giant aneurysm in the left main. So how do you approach this patient actually? So that you can see that the LAD is missing in the proximal portion, and it fills actually retrograde from the circumflex collaterals, and also probably a little bit from the right. And this is, I think, a degree much higher than ectasia as well. Again, aneurysms, and you can see that the only part that is free of disease is the right PDA. And on the same screen, you can see that the patient, that the coronary aneurysm on the left side is heavily calcified as well. So this sort of disease, I don't think it's obviously Kawasaki disease, known patient of Kawasaki. And whenever you see such giant aneurysms coming to you, you don't have to even guess that it is not, it's anything else other than KD. So this patient, as you see on the right side of the screen, he had underwent a bypass surgery appropriately. And there's some discussion here. He had a lemur to LAD and a free reamer that was attached from LAD to actually the right PDA. So this happened in March. He went home. He comes back again in April. And this is what we see on the left hand of the screen, presented with non-ST elevation MI. He was taken to the cath lab. There was a complete occlusion of the left main, distal left main. So in my opinion, if I think now, as we know, and I actually would say, don't go after these. It's a simple, I can end my presentation saying that the large ectatic vessels, there's always a huge problem. And so we went after it, opened it, the balloon, established the flow, and he comes back again in June with again occlusion of the left main in the distal portion. My partner went back again and tried to open it up and with ballooning it. And because the circumflex was not bypassed, and so ballooned the osteal part of the circumflex and LAD, and able to establish flow. 1 minute. Okay, somehow my slides are stuck. Give it a minute. So we established the flow back in this patient, and it still did not actually work, and he still had occlusions in the left main artery. And back in again on June 7th, he came back, and we had the same problem. You can still see my slides, right? So the pathogenesis here is more of a destruction and weakening of the medial layer, and there's chronic overstimulation with endogenous nitric oxide, and ulceration and remodeling consists with advanced atherosclerosis, and the direct effect of elevated inflammatory mediators such as MMP happens in these people with ectatic and aneurysms. So etiology sort of ectasia is most common. It is atherosclerosis, and they also might have a AAA to make sure that you do an abdominal ultrasound or a CT scan to detect that, and especially in people who are more than 50 and smokers. And various vasculitides can be presenting with ectasia, such as Kawasaki, as in my patient, polyarteritis nodosus or Takayasu's, and connective tissue disorders such as Ehlers-Danlos syndrome, and sometimes sepsis. And I used to see this actually in our country, India, where I think whether it was, I blame Sidex because I don't know what else to blame. I think any reusing of wires or balloons, and I think not properly sterilized, and or maybe it's just a chemical reaction from the Sidex. I think it actually leads to aneurysms. And recently, I have not seen any of them, and even in India, but in the past, at multiple presentations, I was like really amazed to look at these aneurysms. And the trauma and cocaine use is also a higher incidence of causing ectasia and aneurysms. Clinical presentations could be anywhere from incidental finding or acute coronary syndrome, as in my patient, or actually they might have arrhythmias, aneurysm ruptures, which is really rare, and it is more than 4 centimeters. I think you should really think of, more than 5 millimeters, you should start thinking about the risk of rupture. And SVC syndrome can happen because of compression of these aneurysms as well. So the classification, small is more, less than 5 millimeters, medium is 5 to 8 millimeters, or giant is more than 8 millimeters. In our patient, it's probably almost like 11 millimeters or so. And there is little evidence that there is a relationship between increased mortality risk and aneurysm size. And morphology is either usually fusiform or saccular in shape. and the presence of concomitant stenosis. In ectasia, you always remember, if it is a small, less than 5 millimeters, I think it is a pre-stenotic dilatation. So those are not ectatic vessels, or sometimes they also have post-stenotic dilatation. Why some people have these versus others, I think is all not very clear. And as we said, that there are several markers that inflammatory markers play a role in these patients. And there's a different, several classifications of these ectasia as a marker system classification described by, obviously, by markers. In the diagnosis is a coronary angiogram or multi-slice CT. Obviously, I think in a non-STEMI and acute coronary syndrome, I'll go for a coronary angiogram. And it could be misleading, and there may be a risk of disrupting the clots with the catheters, and and you might be having a difficult problem to look at the coronary arteries clearly. So sometimes in these patients, the non-invasive methods might be better. Multi-slice CT can differentiate a true aneurysm from a dissection leading to a false aneurysm, and it definitely assists in surgical planning, as has been done in our patient as well. Cardiac MRI has been described in a patient with known Kawasaki disease who presented thrombosed aneurysm presenting as an MI. And this is mainly to understand whether there's any region that actually you should go after. For example, in our patient, we did a coronary cardiac MRI. It showed actually completely infarcted the circumflex territory with EF of about 30-35%, which so we did not go after that anymore. And OCT or IVUS, although both modalities have been described in identifying spontaneous coronary artery dissection, and in these people with ectasia, some of them might have. And OCT's higher spatial resolution allows for more accurate and sensitive detection of the dissection planes as well. So the management, only few studies have thoroughly examined the natural history of coronary ectasia or aneurysms, which has made the management of these lesions controversial. Warfarin has been strongly recommended in Kawasaki disease with giant ectasia or aneurysms. And, I think, many of us advocate for long-term warfarin therapy, and the DOACs are being used now recently, but there is no clear data or randomized trial with the use of DOACs. So the natural history, as you see in the ectatic vessels or the non-ectatic vessels in about 130 patients with ectasia, there's a diffuse stenosis and the stenotic diffuse ectasia is seen in the stenosis segments, and the majority of them happen to be right coronary artery and some circumflex and very rarely LAD. But as you can see in the Kawasaki disease, that may not hold true. It might be even in the left main, as I have shown you as well here. So in the non-ectatic segment, stenosis is seen mostly in the LAD territory as well. So in people, the risk factors and outcomes in patients with coronary artery aneurysms, people with and without coronary artery disease, there is definitely no huge difference in the Kaplan-Meier curve of survival of the coronary artery disease distribution at 5 years. So subgroup analysis from the CAS registry showed that a similar survival in patients who had undergone bypass surgery versus medical therapy in both aneurysms and stenosis only groups. The best recommendation to date is intervention only in patients with high-risk features of myocardial compromise, such as in our patient who had been coming with recurrent acute coronary syndrome. And in the non-urgent care patient, those in whom aneurysms are found incidentally or asymptomatic ectasia, reassuring with ECG and have a negative cardiac enzyme investigations, I think we should be we shouldn't proceed any further. Just reassure the patient. And some advocate a prospective follow-up, a yearly CT scan, which I don't actually strongly recommend. It increases radiation. Patients who require urgent care, especially in acute coronary syndromes and rising cardiac enzymes, I think those are the patients who you should do something about it quickly. And like in our patient, we actually gave the patient IV heparin and in fact a 2B3A, and then he went for surgery following actually which he received DOACs 5 milligrams twice a day of Eliquis, as well as aspirin and Plavix for about 3 months, and then only Plavix and Eliquis were continued. These microemboli happen, and I think we try to do more harm by doing a PCI, as we have done in our patient. So I strongly recommend that percutaneous methods have to be very minimal, and try to not do them in case of those large aneurysms where the wires are probably mucking up much more than what we want to do in these patients. So then the question about giant coronary aneurysm, whether we should ligate or not, is also a question that most people have during surgery, and I think probably the surgeons are not agreeable for ligation as in our patient, but I probably would discuss much further to say, ask them to ligate and bypass all the vessels that could be done, so to save the myocardium from embolization of the clots from the ectatic segments. So giant coronary aneurysms are uncommon malformations that can occur in a variety of disease states, but are usually due to atherosclerosis, and a definitive diagnosis with invasive angiography may be difficult, and CT angiography provides a better assessment, and unstable patients should be treated. Bypass, I think, is much higher than our PCI, because if you think about it, I placed a 6 millimeter stent in a left main one time, but if it is larger than 8 millimeters, what are we going to do? We are going to take the biliary stents and peripheral stents and place them. But as you saw in my patient, I don't think there could be a stent that could cover left main and LAD because of the discrepancy. So you'll be stuck, or the circumflex. I mean, you will be stuck because circumflex is 3 millimeters and ostial left main will be like 15 millimeters. So the stable patient should probably manage conservatively, and Coumadin should be, or DOACs should be advocated. The difficult management decisions are due to the presence of concomitant stenosis, as I mentioned. And from a surgical perspective, the pertinent questions, as I said, that whether the proximal vessel should be ligated, whether the aneurysm should be excised or plicated, and whether the thrombus should be removed. All these are questions, I think, but I know most of our surgery, we had a long discussion with 6 of them, and they felt that it is best to leave alone. And I'm not actually 100% sure about that now, So this patient did suffer recurrent infarctions in the circumflex territory. So thank you very much. I'll stop sharing the screen now, and I'll be able to answer any questions that we have.
Excellent presentation. In fact, literature says zero cases of left main aneurysm, and you showed the first case, perhaps.
Yeah.
Excellent presentation, really. And we'll take question and answer at the end. And I invite now the next speaker, Dr. Rajiv Jauhar. He's the Chief of Cardiology at Northwell Health in New York, USA. And he will enlighten us on culprit versus multivessel angioplasty in STEMI.
Can you hear me now?
Yeah, of course.
Perfect. Sorry. Yeah, Ramesh, that was a scary angiogram you showed. And I think the most important thing to say is try not to wire those things. I unfortunately made a mistake trying to wire one a few times, and they're extremely difficult. It's very hard to find the neck, and causing downstream embolization and problems is very, very high. So my job is really to talk about complete revascularization in STEMI patients, and whether that is the new paradigm versus just infarct-related arteries. What I'm going to talk more about is a common sense approach in doing the right thing for the right patient with physiologic data. So what lesions are significant and what are not? And that's really the most important question. There's a hyperadrenergic state, and we know that the 70% right coronary lesion when you have a circumflex infarct that you bring back the next day is really not 70% and is really a spasm and is down to 20%. So what is the true lesion significance and which are not significant? That's important. So knowing physiologic data and using physiologic data is of paramount importance. So what do we know from STEMIs? Well, we do know that multivessel disease occurs in 40 to 60% of patients with STEMIs, and in larger number in cardiogenic shock. And I'm not going to discuss culprit shock in this talk. It confers higher risks of death, thrombosis, and development of shock. Multiple culprits could be present due to systemic inflammatory state. And treatment of non-culprit vessels historically have not felt, it has not felt to be beneficial. The question is, are they beneficial? And I'm going to discuss the latest data, including a multivariate analysis that just came out last week in JACC. So if you look at the extent, location, and significance of coronary disease, people who have non-infarct-related disease have increased mortality versus people who don't have infarct-related disease. That's well known. We also know that patients with triple vessel disease, it confers an independent predictor of one-year mortality versus double versus single vessel disease. And so this is from the Cadillac trial. So we know that if you have more than just the infarct-related artery, your chance of having downstream either mortality or MACE rates are significantly higher in patients. And so if you extrapolate from our data with complete versus incomplete revascularization, and where we learned from our surgical colleagues who always expressed the need for complete revascularization, the premise came up, well, what should we be doing non-culprit vessels? And historically, we've always said, well, every PCI increases the risk of a problem. Longer, more complex procedures, increased contrast nephropathy, hemodynamic instability, additional procedure time, radiation exposure cost. If you have to do the right coronary, non-infarct related, when you have a circumflex infarct, changing catheters and increasing time. And what I said earlier was the non-culprit lesion severity is often exaggerated. It's FFR negative in about 40% of patients. And follow-up angios show that 20% of what we call significant lesions are now historically less than 50%. So that's important. And so my rule is really to keep it simple. And so here's a scenario that I'll present. So we did last week or the week before. Gentleman comes in with a circumflex acute myocardial infarction, which is clearly thrombotic in nature, what Dr. Meraj called a grade 5 thrombus burden, which we did not extract, by the way, just FYI. He's got a sort of an LED lesion, and then no one would argue, I'm not sure why this is not running. No one would not argue that that the right is not significant. So it's got a circ infarct, a right coronary artery that is angiographically very significant. And most on this panel and probably attendees would say this is physiologically, most likely physiologically significant. And then you have an LED, which is questionable. I can't tell you it's physiologically significant yet. So what would I do in this situation? You know, you fix a circ, but now what do you do next? So we'll talk about that. What are my options? Well, I could do nothing and see how he does. I could do a non-invasive test as an outpatient. And if he shows evidence of ischemia, I could then fix it, bring him back anyway, either immediately or 1 to 3 months later, do it right away, or do it pre-discharge. And the question is, what is the right answer? And of course, using physiologic or imaging technology, which Prashant will talk about in the next talk. But what if it was a proximal 90% lesion? Would you be more apt to doing it in the morning? I mean, sorry, at the time of the procedure or the next day prior to discharge? That is truly the question. So what should we do? Well, yielding to common sense is of paramount importance. And the question I've always had is, do we have enough evidence to treat multivessel disease in STEMI patients, or i.e. complete revascularization? And if you look at the original data from PRAMI, well, PRAMI compared revascularization based on angiographic data. And if you had a second lesion that was 50% or more, not necessarily physiologically significant, they recommended either fixing it or treating it medically. Of course, Culprit looked at several different scenarios. And then recently, FFR use with Dinami, Promulti, and Compare Acute was assessed. And then Shamir Mehta recently came out with a complete study, which published in November in the ACC, in the New England Journal of Medicine. So if you look at the PRAMI data, the incidence of cardiac death, non-fatal MI, or refractory angina was significantly lower in complete revascularization versus non-complete revascularization, with a risk reduction of about 65%. If you took out refractory angina and just looked at death and non-fatal MI, doing preventive PCI still resulted in about 64% risk reduction in event rates with death and non-fatal MI. And obviously, all these studies are not powered for to assess death, so they're really powered for, and they're mostly due to non-fatal myocardial infarctions. And all these MIs were spontaneous. Peri-procedural MIs were not counted. And PRAMI showed early benefit of event rates with preventive PCI, but it has limited applicability because we do not treat 50% lesions or ignore tight lesions. And so, or what we consider tight lesions. So PRAMI was sort of dated right when it came out. But PRAMI and Culprit, which also looked at outcomes with MACE and showed that complete revascularization was better, and led to the changes in our guidelines, also is not really real world data. And so Culprit looked at immediate versus staged PCI, and they showed that if you did it prior to discharge, the patients did equivalently better. So the reality is that the initial data looked at complete revascularization as a positive means. And the thought process that we had when I was early in my training was the fact that you don't want to touch non-infarct related arteries, the fact that you're increasing contrast load, the fact that you're increasing procedure time, and the fact that you're increasing risk of thrombosis by doing multi-vessels was really not borne out. But real life cardiology has unfortunately looked at the oculostenotic reflex, looking at the lesion in terms of severity as opposed to physiologic significance. And Mishra came out with the complete data, which if you look at, you looked at STEMI versus with multi-vessel disease and successful PCI in the culprit lesions. And then they looked at complete revascularization in about 2,000 patients and culprit lesion only revascularization in about 2,000 patients. And they followed up these patients for 3 years with really GDMT with aspirin and a PGY12 inhibitor and aggressive statins and the classic risk factor modifications. And what they showed, which came out in November of last year, which was a really one of the largest studies on this topic, they showed that cardiovascular death or new MIs were much better, were significantly improved with complete revascularization. And if you looked at, if you added cardiovascular death, MI, and revascularization, it was still better in these patients. So compared to culprit lesion only PCI, a strategy of non-culprit lesion PCI with the goal of complete revascularization either early during the hospitalization or after discharge within 3 to 4 weeks confers similar benefits to these patients. And the benefit of complete revascularization was shown with death or MI over the long term after 45 days. There was really no statistically significant differences in outcomes between randomly allocated therapies in either the index hospitalization or after discharge non-culprit PCI group. So that is important to know. And that our guidelines have evolved after culprit and PRAMI came out in 2015. And so STEMI has been upgraded and modified to really a class 2B recommended to include consideration of multi-vessel PCI in the right common sense scenario. And if you look at the recent multi-analysis that just came out last week, it does favor multivessel PCI in the studies. Varanasi from Nebraska just published this on July 13th, looking at primary efficacy outcomes, looking at all-cause mortality, reinfarction, and showed really, and again, it's a multivariate analysis and it's retrospective and it's looking at all the different studies, but did show that if you look at cardiovascular mortality and repeat revascularization, it does favor multivessel angioplasty and treatment of a non-infarct related vessel. So what do I do? Well, I absolutely do consider if the EKG symptoms, hemodynamics don't settle, if it's angiographically tight, where there's no question that it's significant, I do it there or during the hospitalization. I have a very low threshold for doing FFR or IFR in these patients. And if it looks angiographically significant to me, I rarely send the patient out and do a non-invasive test. So in my patient, for example, is this working? I did an LAD IFR on that. After I fixed the right, I did an LAD IFR, and it was not significant. It was not significant with an IFR of 0.91, and so I left it alone. But I think, a lot of my colleagues would have fixed that. And so I left that alone, fixed the right, and sent the patient home, and he's doing well. So what is my STEMI approach? Well, if it doesn't have multivessel disease, well, we're done. If they do, are they in shock? Well, and I'm not going to discuss culprit shock here. If they're not in shock and it's uncomplicated, if it's not uncomplicated, I hold off and I stage it. For example, if they have renal disease or something else. If it is uncomplicated, then I'm very inclined to use FFR. When I trained in the 90s and early 2000s, we didn't have FFR. So we used angiographic ocular stenotic data. But learning from my younger colleagues, I think IFR, FFR is of paramount importance in really assessing what is truly non-infarct and whether it's significant or not significant. And so I am a strong believer in FFR guided PCI for intermediate lesions. Obviously, if it's very significant, then I am going to fix it immediately. So our goal is to improve survival in event rates, but we need to treat the patient and the lesion. And that's important. So to me, I find a happy medium between multivessel PCI versus culprit only PCI. And I think the correct plan is probably to meet in the middle. Looking at the patient, these studies have not really looked at octogenarians who come in with acute MIs or really specific subgroups of patients. What about the patient with renal disease, other diseases, other comorbidities, so diabetics. So the correct plan is probably to meet in the middle between multivessel PCI and culprit only PCI. So I know I'm running out of time, but common sense approach to lesions and patient care. And one can achieve all the degrees that the world has to offer and still lack common sense. But all the degrees in the world are no substitute for common sense. So when you do these cases, use your common sense and do the right thing for the patient. Thank you very much.
Excellent. Brilliant talk. And we'll take question answer at the end. I invite now next speaker, Dr. Prashant Kaul. He's the director of Cath Lab at Piedmont Heart Institute, Atlanta, America. And he will enlighten us on imaging, intravascular imaging in ACS, when and why.
Good morning, everyone. Thank you, or good evening for you, all of you in India and Asia. Dr. Bang, thank you very much for the kind invitation. Can you all hear me?
Yeah, of course. We can see your slide, we can hear you.
Okay, perfect. And great to be together with Meraj, Rajiv, and Ramesh once again. Hope everyone is staying safe. So in the next 10 or 15 minutes or so, I'd like to discuss with you the ideas, thoughts, and data on intravascular imaging, not only in acute coronary syndromes, but in PCI in general, when and why. So here are my disclosures, none too relevant to this discussion. So let me just start by asking you all just some questions, and we can maybe think about this in the discussion afterwards. But, you know, I often sort of ask...
Participants can reply in the chat.
Yeah, we can, you can sort of think about these questions and we can discuss further. But I'm just trying to understand in what proportion of your PCI cases do you use in imaging, intracoronary imaging? Do you never use it? Is it less than 5%? Is it less than 10%? So let's have you think about that a little bit. And then if you are using imaging, what kind of modalities are you using? Are you using IVUS? Are you using optical coherence tomography, or are you using both? And if you're not using imaging routinely, so if you're using it in less than 10% of cases, why is that? Is that because you feel that there are no data that support the use of imaging? Is it because you think that it takes too long? Is it because there are cost constraints and you feel that it's too expensive and maybe not cost effective? Maybe it's not available in your lab. And also we hear often that, you know, we don't really understand how to interpret the images. And so that may be another reason why people are put off. But these are just some questions for thought. But I'll tell you, universally, almost across the world, and especially in the United States, the use of intracoronary imaging is woefully low. These are some data that we had collected a few years ago. And we basically found that the use of intravascular imaging was somewhere less than 5% across the board. And if you broke that down into where it was used, sort of teaching hospitals versus non-teaching hospitals, the more academic hospitals certainly were using IVUS and OCT much more commonly than the non-teaching hospitals. But so, do we have data to support the use of imaging in PCI? So here is the IVUS XBL randomized clinical trial. This randomized 1,400 patients to either IVUS-guided PCI or angiography-guided PCI with a primary endpoint, which was a composite MACE score of cardiac death, target lesion myocardial infarction, or target lesion revascularization at 1 year. And you can see here that there was a significant reduction in this primary endpoint in the IVUS-guided group. So 2.9% only in the IVUS-guided group compared to 5.8% in the angiography-guided alone guided group. Well, what about other trials? Are there other trials? Well, in fact, there are a number of trials. And in fact, here is a meta-analysis of 7 randomized controlled trials, over 3,000 patients, including long lesions. And again, the data certainly favored IVUS guidance. And IVUS-guided PCI in this meta-analysis was associated with significantly larger post-intervention minimal luminal diameter. It was associated with a greater reduction in the diameter stenosis, also a reduction in the risk of MACE, and there was a borderline lower risk of stent thrombosis and cardiovascular mortality. So here is even more data. This is not a randomized trial, but this is a very large prospective multi-center all-comers study, which included acute coronary syndromes, over 8,500 consecutive patients in both the US and Germany. And they conducted a propensity-adjusted multivariable analysis looking at the impact of IVUS guidance on 2-year outcomes. And this is from 2-year follow-up data from the ADAPT DES study. And you can see, looking at MACE, definite or probable stent thrombosis, MI, target lesion revascularization, all at 2 years. For all of these clinical endpoints, IVUS guidance was statistically superior to angiographic guidance alone. So more recently, we have data from the ULTIMATE trial, which was initially presented a couple of years ago at the TCT meeting and simultaneously published in the Journal of the American College of Cardiology. And this was, again, an all-comer study, which included acute coronary syndrome patients and randomized patients one-to-one to either getting IVUS guidance or angiography guidance for PCI with a primary endpoint of target vessel failure at 12 months, and it was powered for superiority. And looking at the primary endpoint of target vessel failure at 12 months, again, significant, statistically significant reduction in this primary endpoint with the IVUS guided group, 2.9% only in the IVUS guided group compared to 5.4% in the angio guided group. So when should we be using, so that covers the why we should be using intravascular imaging. And I hope I've presented fairly robust data showing you the benefits of using it. But how and when should we be using this? So you could make a strong argument to use intravascular imaging as a pre-intervention assessment during lesion deployment, during stent deployment and lesion preparation, and also to assess post-procedural complications and assess the stent. So specifically, you are interested in understanding the severity of the plaque and vessel sizing. Is there calcific plaque? Is there any spontaneous dissection? And these are all important to understand as you pick your stent sizes and understand what therapies are needed. Do I need atherectomy? Do I not? Should I not use atherectomy because there's a dissection? And then during and post PCI, how much malapposition or underexpansion is there? Do I see any tissue prolapse? Is there edge dissection? These are all things that you will not be able to understand unless you use intracoronary imaging. And so there is a nice review that I would point you towards in the European Heart Journal, looking at the a sort of a proposed treatment algorithm using intravascular imaging for ACS in particular. And so for ACS patients, why might you need intracoronary imaging? So after your initial angiograms, you know, things like understanding the culprit lesion. Is the anatomy ambiguous? Is the culprit lesion unclear? Do I need to use atherectomy? Is there any associated dissection? These are all some of the imaging reasons, as it were, that you will be able to elucidate when you use imaging in the setting of acute coronary syndrome. So not only to further characterize the lesion, but to guide your intervention. Very important. The problem, unfortunately, is many of the guidelines have lagged far behind the available randomized controlled data. So, for example, here in the United States, our PCI guidelines are in the process, in fact, of being updated. We don't have that document available to us yet. But the most recent guidelines we have are, in fact, from 2011. There has been a lot of data that we have seen now since then over the last 9 or 10 years. And so, unfortunately, the use of intracoronary imaging is still at a class 2A recommendation, unfortunately. And personally, I feel that this has been a hindrance to more wide-scale adoption of intracoronary imaging. And so let's see, let's move on here. So, and the European guidelines as well are in a similar spot and have not updated their guidelines as much either. So to try and kind of put all of this together and put this all into perspective, let's end with an interesting case that I would like to present to you here. So this is a 58-year-old man who is has the usual risk factors. He's a smoker, he's hypertensive, and he presented to the emergency room with typical anginal symptoms, found to have a troponin of 2.3. There were EKG showed non-specific ST wave changes, and he was referred for diagnostic angiography. So here is the initial angiogram, and you can see there's what appears to be some type of lesion in the mid right coronary artery. And before I go on, actually, let me sort of pause for a moment and just ask my fellow panelists, what do you guys think here? So you have and I'll tell you that the left system is normal. What would you guys think about this? Ramesh, Perwaiz, Rajiv, Vijay, any of you?
I think, Prashant, to me, it looks like a borderline lesion. And very short, discrete borderline lesion. I would not, at the moment, I would do FFR and decide whether do we need anything further to be done for this particular block.
Correct.
Yeah.
That's a great option. Any other thoughts?
Yeah,
I agree.
There's a pretty decent. It's actually the focal lesion is probably the tightest, but there's a long segment of mild to moderate disease in that entire right from the prox RB marginal branch all the way down probably to 20 to 30 millimeters prior to the distal bifurcation. So that could all be significant.
Yeah, I'm sure it's a physiologically significant lesion. And I'm sure if you IVUS this, you would see a lot of plaque burden.
Yeah, no, absolutely, absolutely.
Not physiology, not physiology.
Oh, 100% physiologically. I'm sure it would be positive.
Yeah, so great, all great points. And so let me show you what happened next here. So this was done at an outside hospital. So this operator did do FFR, and the FFR of this lesion was 0.65. Okay, so, in keeping with what everyone's saying, like, maybe it appears to be a little bit of a borderline lesion. He did present with a non-STEMI, reasonable option next to do FFR. So let me ask you guys, then, what are you going to do next? Now that you have this abnormal FFR?
Just one point that I felt why it came positive, because the lesion appears to be long one. Has it been a discrete lesion, then it may not have come positive. But it's a diffuse plaque. It is diffuse plaque from mid RCA to down below, almost you can say about 30 millimeter.
And I'm sure if you just stented this thing right now, a lot of people would probably use a 2.5 stent. And I'm sure it's at least a 3 or larger vessel size.
Interesting comment, Rajiv. Very interesting comment. And
the right coronary is always undersized. I mean,
what is your take, Prashant, on it is said from earlier times that whenever we do IVUS, we overestimate the size of the vessel?
Yeah, I mean, I think that gets into the nuts and bolts of IVUS versus OCT vessel sizing, whether you use lumen to lumen area versus external elastic laminar area. And so if you are using luminal size by IVUS, yes, you might overestimate a little bit and underestimate if you're using OCT.
Particularly if you are using 40 megahertz machine.
Yes, so there is a, yes. Yeah, so it's important to sort of bear that in mind. But I think that's your point is actually completely valid. But I think that gets into the more sort of fine details of imaging, which is important. But I'm trying to make a sort of a bird's eye view case, firstly, of getting people to use imaging. So the point I'm making here is as follows, and Rajiv's point is a very important one. So this was a positive FFR. So the next step was that a 2.5 by 12 millimeter stent was used here to treat this lesion. This is what happened. And here is the final result. So what do people think here? Is this, you think this is a decent result? It looks, angiographically, it looks a satisfactory result, nice TIMI3 flow. Looks like the stent has been reasonably expanded, and a nice result here. What would you guys think? So, you agree?
I think this is the whole point. It's angiographically, it looks pretty decent angiographically. Yeah. However, we all know that my personal rule of thumb is that whatever size you think this looks, it looks at least a half a millimeter larger than it is, when you image it. So this is one, if you image it, you'll probably see a stent that's probably not exactly where it should be.
Can we have Ramesh also? Ramesh, where are you? Ramesh?
He's on call, so he may have to go.
Yeah, I'm right here.
Yeah, okay.
I have to, sorry, someone call.
Okay.
You look very scary right now.
Okay, so let me show you how this played out. So here we are. So this is the pre and post, 2.5 by 12 millimeter DES, nice angiographic result. This was in March 2016. 8 months later, just 8 months later, in November 2016, in the same year, the patient now presents again with repeat symptoms, and now the troponin is even higher. It's 5 on this presentation, and here is now the angiogram. Okay, this is just in 8 months. So now he's at our hospital, so we kind of look through it and try and understand what happened here. And the first thing that we did after we wired this lesion was to image the vessel. Okay, and as you can see here, the stent is woefully undersized in what is a 4.0 vessel. So if you look at this, this is a 2.5 millimeter stent in a almost 4.0 vessel. Okay, now there is nobody, I would submit, that angiographically would be able to predict, apart from obviously the experience, and of course Rajiv made a very valid point and effectively foretold that this is exactly what would happen. But otherwise, angiographically, the point I'm making is very difficult to determine the actual vessel sizing, especially in acute coronary syndromes, because it's especially in STEMIs to that point too, because the vessels tend to be much more vasoconstricted. So routinely, especially in right coronaries, you're always going to undersize the vessel.
And no one would have used a 4.0 vessel. I mean, no one. I don't think anyone I could think of at the highest they approved without IVUS.
Nobody, exactly the point. Nobody would use straight off the bat. No one would use a 4.0 stent in that vessel without imaging it, because it doesn't look like a 4.0 vessel. So then, basically, we then reballooned the in-stent restenosis and restented with a 4.0 by 20 stent, obviously optimized by IVUS, since now we're going down that road. But the other point here to make is that now angiographically, they both look very similar still. And if you don't image, so these are the two pictures side by side. On the left, and the same segment, the same vessel, the same patient. On the left is a 2.5 millimeter stent. On the right is a 4.0 stent. Okay. And unless you do intracoronary imaging, there is no way to know what you're dealing with. Okay. And so I would submit to you that that because of cases like this, you should have a very low threshold for intracoronary imaging.
I think this is also a good example, Prashant, sorry to interrupt, is a good example.
No, go ahead.
Good example to say that, many people would say this is stent failure. This is failure of the drug, failure of the stent, failure of drug-eluting stents, but this is actually probably not stent failure, and with respect to our profession, is probably interventional cardiologist failure. And I think this is what we need to do a better job of if we really want better outcomes for our patients.
Absolutely. Absolutely. Couldn't agree more. So then these are my last few slides. Let me just sort of summarize the sort of take-home points now. So when should you be using intracoronary imaging? Personally, for me, I have now adopted over 95% strategy. So in over 95% of my cases, I use intracoronary imaging.
Prashant, can I ask you, which machine do you use for IVUS? 60 megahertz, is it?
Yes.
Okay.
Yes. And we use both IVUS and OCT, and we have the Philips Volcano IVUS system. So when should you be using intracoronary imaging? Well, in my opinion, I think you should be doing it when there is a large territory at risk, if the stent were to fail, or in scenarios that might be associated with a high risk of stent failure, and in all acute coronary syndrome. So looking at patient factors that you should certainly have a very low threshold, patients who are diabetic, end-stage renal disease, acute coronary syndromes, we used to say if you were needing to use a bare metal stent for whatever reason, then in those cases, especially because stent failure is high, you should certainly be using it. I've crossed that off here because personally, I think there's no real role for bare metal stents anymore. So that is a moot point. I don't think there's any situation where you should use a bare metal stent. And then certainly anatomical and procedural factors. So any aorto-osteal lesions, left main disease, certainly bifurcation stenting, absolutely where you have a prior stent failure, like exactly in the case that I've shown, where you're trying to determine the mechanism of the stent failure. Was it stent failure or was it actually an iatrogenic issue, as we have decided here? And certainly all long lesions, and particularly when you're understanding calcium. So the decision to use atherectomy or should not, or not to use atherectomy, need not be a guess. There's always this sort of, oh, should I do atherectomy or should I not? There's no need to guess. Just use imaging and understand the burden and extent of calcium. If there's more than 180 to 270 degrees of calcium, then you have your answer. And certainly with calcified lesions also to optimize stents. In ACS in particular, since the topic of this session is ACS, specifically, imaging can help you to detect thrombus, and this may help facilitate identification of a culprit lesion if it's not necessarily obvious just by the angiography. OCT may be a little better than IVUS in this regard. Very important, as I've just mentioned, for understanding plaque etiology to guide and tailor therapy. And then, as I've said, in non-STEMI patients, when the culprit lesion may not be angiographically evident. And I'll make a brief point about SCAD, spontaneous coronary artery dissection. In cases where you're suspecting it, there may be a role for using imaging, but I caution you when you're using imaging for coronary artery dissection, because putting a wire or instrumenting the artery with a dissection can make things much worse. And especially with OCT, if now you've got to inject a bolus of contrast, you can certainly propagate the dissection and make things a lot worse. So only reserve imaging in SCAD if there is some clinical or hemodynamic instability, or if you're not sure what's happening, if the angiography is not clear and you need to make the diagnosis, then consider it in that situation. And certainly there's been a discussion of this syndrome such as Minoka, MI with no obstructive coronary arteries to further characterize the vessels. So in summary, this is my last slide. I'll say that we have now significant randomized controlled trial data supporting imaging guidance for PCI in all comers. I do accept that there are several barriers to adoption worldwide, whether that may be cost, whether that may be time. But at the end of the day, we're all here to take care of the patient and to give our patients the best possible PCI outcomes. And so I think the onus is on us to perfect PCI outcomes as much as possible. And I think imaging is very, very important to do that. And please have a low threshold for imaging in the scenarios that I've just described for PCI guidance and optimization. And hopefully the case that I've shown you will be a cautionary tale and encourage you to use imaging more routinely. Thank you.
Thank you very much, Dr. Prashant. Kaul, very nice talk. Excellent case example that you showed. How imaging has made the difference in selecting the size of the stent.
I think it's very important also, Vijay, to mention that when you have table-side ultrasound, as opposed to a standalone machine, it makes a big difference. I mean, when we had just a standalone machine a few years ago, it was cumbersome to do IVUS. Now that we have table-side, it literally takes 2 minutes to get really informative data.
Where I was professor, head of cardiology at JJ Hospital, we had an IVUS machine integrated in the cath lab. So all we have to do is just pull out the catheter, plug in, and you are on for the IVUS study.
I would say that's one of the most common reasons of certainly for lack of adoption or low adoption is the integration piece. That's a very important thing. And I think it also speaks to the issue of cost. Interestingly, in places in East Asia, so Japan and other Asian countries, the use of intracoronary imaging is almost 100%. But that's because their whole reimbursement structure for intravascular imaging is very different. And so that, I think, has also been an issue. And I have proposed to some of our societies that not only should there be some reimbursement, but it should be a quality metric. Intravascular imaging should be listed as a quality metric, and we should be held accountable to those metrics.
Okay, recently there was a paper presented and data presented of long-term follow-up, particularly for optimization in group of patient randomized control trial. Group of patient optimized by intravascular imaging and group with only angiographic guided optimization. And both studies have shown no difference in outcome. No difference in outcome. And it's a large study presented in PCR, absolutely no difference in outcome. MACE rate and death identical. Because these days what has happened, we deploy the stent and post-deployment, we optimize it with the NC balloon at a higher pressure, maybe 0.25 bigger size balloon. That has, I think, changed the scenario quite a lot. Almost optimization is now a regular practice. Each one of us, after deploying the stent, we optimize it with NC balloon invariably, whether we do imaging or not to do it and not done the imaging. That is one thing. Second, my question is, when you have a STEMI, suppose if you have a STEMI and if you want to assess the size of the vessel using intravascular imaging, for that matter, you have to use IVUS. Suppose you have a 60 megahertz IVUS machine with co-registration. It gives a fantastic picture, 3D pictures, so that optimization, you can see like a tube, going. And that looks very good, particularly OCT images, where OCT has a very good resolution and pictures looks very beautiful. But in IVUS, if you do IVUS in a patient with a STEMI, you tend to undersize the vessel. The reason being, the thrombus adhering to the wall of the vessel, and you can end up, or you can even propagate the thrombus distally and may end up having a slow flow. What is your take on this?
Yeah, the issue of imaging in ACS, I think, is independent of the possibility that you may have distal embolization with a post dilation or so on. So I don't think that in the scenario that you just described, that you're saying that there may be some distal embolization. I don't think that's because of imaging. I think that's more because even if you didn't image and you were just post dilating, it's likely that you would have still seen that. But I think the important messaging needs to still be that imaging is essential. So regardless of, if you're oversizing by using IVUS, then it's possible that your interpretation of IVUS needs to be tweaked a little bit or recalibrated. Like and I don't mean machine recalibration, I mean the operator needs to recalibrate how they interpret the IVUS imaging. Because OCT and IVUS, and I'm not here to promote one or the other, whichever, take your pick, use one, but use something.
What I told you is a Japanese study. Japanese have reported that if you do a IVUS in a patient who's STEMI just for sizing purpose, you tend to underestimate the size vessel. This is Japanese study, a large number of patients. Right. Because Japanese, they, as you said, that 95% or more, they almost 100% they do the imaging. So that is and in those cases, in a STEMI setup, you cannot do obviously the OCT, because OCT will require large amount of dye, and then catheter going forward and then coming back with the force, and dye has to be injected with the force. So it may not be suitable to use particularly the OCT. I think it should be okay, but provided you have cleared the vessel from the thrombus by at least giving some intracoronary lytics or something intrathrombic. We have a great experience with intrathrombic intracoronary lytic using Oxford balloon. We inflate the balloon, make smaller hole, and make it like a perfusion balloon and give the drug, directly inflate the drug into the thrombus. In short time, you will see thrombus disappearing. There are people who have directly injected in the coronary the lytics, half dose, and it works very well. Only thing, lytics we cannot use if patient has received a lytic for some reason before coming to PCI center outside. Within 24 hours, we cannot use the lytic. But after 24 hours, half dose lytic, it is allowed to use because half-life of the lytics is a shorter. Am I right or wrong? What is your take on this?
Yeah, so in general, we very rarely use intracoronary lytics. We practically have never used it, or very rare that we give it. And we also don't use intracoronary 2B3A agents either in general. In the case of a patient with very large thrombus burden, similar to, maybe not as extreme as Perwaiz sort of was demonstrating, but if there is a heavy thrombus burden or a suboptimal angiographic result, we would rather just put the patient on a 2B3A intravenous for 12 to 18 hours or longer, and then bring back. So we have, so that's typically been our personal approach here. But we, in general, have resisted the temptation of giving lytics just because I think the bleeding risk and the data, the risk benefit we don't feel is in favor. But we certainly, to your earlier point, we have certainly used OCT in STEMI cases. And it's been very helpful to understand clearly you get some beautiful images of the ruptured plaque and thrombus and so on. But of course, that is, after you've done an initial balloon inflation and you've reestablished TIMI3 flow and so on. Perwaiz, let me ask you, so what is your sort of thought about using imaging in ACS patients or STEMI patients? Do you do it routinely? Like, what is your sort of MO?
So no, we do. We will typically use imaging. Not everybody, of course, but many of us who do STEMIs will do imaging. It depends. Some operators will do imaging at the start, after restoration of flow to size their stent. Some will do it to optimize their stent post PCI. I think I think that with Dr. Bung's point, and I think the Japanese study is a legitimate, point of discussion. In the sense that I think depending on your ability to interpret the image for IVUS and OCT, obviously less so given the STEMI and the risk for distal embolization of thrombus with persistent injections, I think, maybe something to be worried about. But, with IVUS, I think your ability to interpret that IVUS image, I think is very important for you to appropriately size your vessel. And I think that's where the interpretation of IVUS is very important in that particular aspect. But I feel like if you realize that during a STEMI that you are typically going to undersize that vessel with angiographic alone strategy, then I think you really need to do some imaging to really appropriately size the vessel. Two points. One, you really want to try to avoid post-dilatation as much as possible in STEMIs. Obviously, whatever thrombus may be behind the stent, the concept of this cheese grading and further distal embolization of that thrombus is another factor which we don't want to continue to propagate. You really can't take modern 2.5 stents to like 4.5. It's really not an intelligent way of post dilating because there is the concept of conservation of mass exists. So, there's only so much mass in a 2.5 stent. So trying to make that stent 2 millimeters larger than it is very difficult to do. That's another point of that people must remember. So you should be in the ballpark of where you need to be. I would IVUS the vessel, sometimes just even IVUSing the non-thrombotic segment proximal to the thrombotic segment or distal to it can help as well. Just give you a rough estimate of what you're dealing with. And then maybe half size down that stent a little bit, and then be able to post dilate at the end after giving your appropriate pharmacotherapy as well. It's not as simple, I think, as just popping a catheter down and putting a stent in. I think there is a little bit of experience and interpretation that is necessary in a case-based scenario. But it's definitely something to consider. If you're putting a 2.5 millimeter stent in a proximal vessel of any kind, it's probably undersized, right? So I think that these are just some simple rules that we all have to realize, that no one was born with a 2.5 millimeter proximal LED, proximal right, or proximal circ. So we all need to realize that's probably not the case.
Perwaiz, coming back to the large thrombus burden, you have a TAPAS trial, the TEST trial, and thromboaspiration, thrombosuction, and like GP2, 3B, GP2, 2A and 3B, they have all failed in large thrombus burden. I'm talking only in large thrombus burden. Sure. They all fail by various randomized controlled trials. They are unable to control 90% mortality. They are unable to bring down any mortality. So all that has gone. So how do you deal? Because if you balloon the large thrombus burden, then you're likely to have slow flow, no flow, because it's a red plus white thrombus. It is going to clog the microcirculation. So to prevent microcirculation clogging, like, for any STEMI outside, if patient reaches a non-STEMI, a non-PCI center, he gets, in any case, lighting. Why he gets lighting? Because there is a red and white thrombus, and he doesn't get GP2 or B or 3A. He gets lighting because that will take care of red thrombus also, in addition to taking care of white thrombus. So similar pretext, in India, we tend to use intracoronary lighting into the thrombus, directly injecting into the thrombus, like we do it for peripheral arteries. Sure. Because peripheral arteries, hours together, continuous, we give that treatment, lytics, and then we see the results are good. Particularly thrombus load is very high in peripheral artery because their size are very big. In carotid, they give these lytics. In intracerebral arteries, they give lytic. So same way in the coronary, lytic works very well, provided you use half dose of lytic. Like retiplase, if you 10 milligram, 10 unit, if you give in the intrathrombic, slowly, it works very well. On the table itself, the thrombus disappears. No slow flow, no reflow phenomenon occurs.
I think this is a practice. I think that I would say that in the U.S., I think Prashant will agree with me, is that this is something that we typically don't do.
You don't use,
and if you look at the literature in this particular space, it's a pretty much data-free area, in the sense that there really is no benefit. I don't know of any clinical trial that has shown benefit of the use of intracoronary lytic therapy.
We have a multiple center doing the same thing, intracoronary, intrathrombic, lytic, half dose, 10 milligram, and some 40-50 cases. There's no randomized control trial, 40 cases and 50 cases trial is there, and that's shown great result without having any major bleeding problem in using this patient.
No, I think that's
what I would say is that that's fantastic if that's happening, but if that's the case, then more people should know, and you should publish that data.
So publish in Indian Heart Journal.
Yeah.
I think it's important because I think that as you said earlier, the use of pretty much any intracoronary antiplatelet agent at the present time has really not shown benefit, right?
Absolutely.
And I think including Cangrelor, which didn't show benefit
That's why it's not taken up. It's not popular at all in America. Also, Cangrelor is not taken up.
Correct.
Another thing, a physiologic study in STEMI, Prashant. Again, FFR is not reliable in STEMI. So,
so that's a good question. It's not reliable in the culprit vessel, But
Yes.
we do have a number of studies that Rajiv alluded to where there is a role in the non-culprit vessel.
There is a role in non-culprit, even
Yes.
in acute STEMI stage.
Even in the acute STEMI in the index procedure.
Index procedure. Okay.
Correct.
That's
In
very
the
good.
non-culprit
In
vessel.
non-culprit.
Culprit
Very-
vessel, it's of no value.
No
I
value.
mean, it obviously makes no sense to do it there.
Absolutely. No value at all. So in your practice, when you see a case of STEMI, suppose, how do you go forward to treat the patient? Do you do all those STEMI score, gray score to decide high risk, or only just do troponin? If troponin is positive, straight away, invasive strategy.
Yeah, typically, the non-STEMIs that we see, they're triaged up front, and the real non-STEMIs, troponin 2, 3, 4, or higher. Invariably, unless there is some reason not to bring them to the cath lab, they have kidney disease or some other issue or stroke or something like that, almost invariably those people will come to the cath lab for an invasive assessment at some
And
point.
how many of them you leave it for medical management and discharge them?
The minority. And I would say that there are some patients who fall in an in-between category where we might think about doing a CTA, coronary CT angiogram. And that would be...
Do you find it useful?
CT angiogram we found it very useful, especially because now, we're combining CT angiogram with CT FFR. And so CT FFR has been very, very helpful, and it allows us to, understand specifically, before there was a much higher rate of subsequent follow-up angiograms with the CT after the CT. But now with the FFR component, many of those cases we're not needing to bring to the lab because we're getting good information from the FFR.
What is your approach in ectasia, coronary ectasia, without any significant block or with the significant block? Both the situations.
Yeah, I mean, any coronary ectasia, my first reaction is to step away and run away as far as possible, from an interventional standpoint. I mean, I think Ramesh's point was important and well taken, which is that it's you have to try and minimize any instrumentation, and because inevitably you're never going to win because there's no scaffold or stent that is going to be large enough, and there's no scaffold or stent that is going to stay open without any huge thrombus risk. So I think the goal should be to try and minimize any instrumentation. So often our first thought might be to stop and either give lytics or IV 2B3A for a couple of days, and then just to try and manage them conservatively. So our goal is to try conservative management, stabilize the patient, and then try and have a heart team discussion with the surgeons to offer the best strategy, which may involve some kind of surgery or ligation.
Suppose you have a single vessel, a right coronary, pseudoaneurysm, big size, or even a true aneurysm, more than 4 times of the adjacent vessel. That's when we call it a aneurysm. With a big neck, it is aneurysm, true aneurysm, and small neck, it is pseudoaneurysm. So when we have this aneurysm, there is a study which is reported stent-assisted coiling. Means you stent across the aneurysm neck and then inject the coils into the neck so that they don't prop out into the lumen of the main artery. And that seems to be quite good, reasonably good result in selected cases. I mean, you need to select the case.
Correct. No, that's actually a good point. There has been a described technique. Yes. It does require a little bit of finesse to do that.
Finesse and skill, of course.
Of course, because clearly if any of that, the coil material or anything goes down the wrong way, you've now occluded a vessel that you may not get open again. But in addition, there are other things that people have tried, and certainly if it's a very narrow neck, There have been cases where I've used a covered stent. And certainly with the, we now have the PK Papyrus stent available to us, which is a much better platform than our previous Jomed stents. So, we might be more inclined to use that stent in a situation like that. It's, again, on a case-by-case situation, assuming the neck and anatomy is favorable for a treatment strategy like that.
Earlier, for any aneurysm, mycotic aneurysm or any other aneurysm in the coronary artery, big size aneurysm producing symptoms of acute coronary syndrome, those patients are considered. And the interesting part is earlier there was only recommendation for bypass surgery for all this, single vessel, and you have a frequent problem with this bypass surgery. But now lately, even they are reporting that you can put a covered stent across, and that also is comparable result, because covered stents are now thinner wall, they have better technology. In one, the one Graft Master, it does have a pericardial tissue to cover, so it's good result that gives. So what do you have any experience? You said you have some experience.
Yes.
I have some experience.
Yeah, we've had a number of cases. It's interesting that we have seen a few coronary aneurysms like that, and where we've treated with covered stent, with some with coiling. But we've also seen a number of vein graft aneurysms. And that's another sort of situation that then there are other options there. So, there's been cases where we've had very large giant aneurysms in the mid body of a vein graft that is supplying a CTO vessel, for example. And so we might then decide to open the native CTO and then coil or close the vein graft. And so we've done that certainly a number of times.
Yeah, one case was shown, this case that you're describing,
that
was shown by your colleague.
That was my case, actually.
That was your case. He told also that was your case.
Yeah, so we did that, but in that case, what we did is I put in an Amplatzer plug into the body of because it was like the neck of the aneurysm was about 10 millimeters, 8 to 10 millimeters, so very large.
But the plug holds it?
Yes. The plug holds it, and we even have 6-month follow-up data where we did a CT angiogram, and the whole graft had occluded nicely, and then the native vessel was still patent. So I think the point is that these situations are unusual, uncommon, and there is no generalized one-size-fits-all strategy. You have to understand that there are a number of different options available to you, right from conservative management to these coils or plug closures, right the way through ligation and all of these things. And it's important to have a heart team discussion with your surgeons to then, for your particular patient, to customize the solution for your patient.
Good. Now, as I said earlier, the optimization data, no difference at all. Imaging, no imaging. But 11-4 trial result will come somewhere in 2021.
Yes,
correct. That is when perhaps this debate on whether to opt for optimization, imaging, intravascular imaging to be done or not done. Because if there is no outcome benefit, then it's not worth the exercise, particularly for optimization. Imaging will remain for many other reasons. I had one patient, very interesting case. Young lady presented with a sudden cardiac arrest. She was revived on the road and brought to the hospital. So we naturally, after stabilizing her, we did an angio, and we found that she's got a mid-LAD, generalized narrowing, almost 20 millimeter long narrowing in the mid-LAD. So we decided to do, because there was no evidence of plaque anywhere, and young lady, 42 years old. So we decided to do a OCT. And OCT revealed that it is intramural hematoma compressing the artery. In spontaneous, which is fibromuscular dysplasia. We know that it is a fibromuscular dysplasia. So we left alone, because if we stent it, then the intramural hematoma will move down and create a problem. So we didn't stent it, we just left it alone. And we called the patient after 1.5 years, 2 years, and angio was absolutely no.
Yeah, no, that's interesting. Yeah. You know, in some situations.
In another patient, we stented. That was 55 years old male patient. So usually these FMD is very, very well known. Fibromuscular dysplasia is well known in female patient, usually, particularly after postpartum, usually. But male, we have hardly heard of anything. In RCA, we saw proximal tight lesion, patient classically symptomatic. Without doing any intravascular imaging, we stented the patient.
So
the moment we stented the patient, the intramural hematoma moved beyond the stent, the distal edge of the stent. And then there was, from TIMI 3 flow has come down to now TIMI 1 to the distal artery. So we imaged it to understand what has happened. And imaging found intramural hematoma, which has moved from here to there. So stenting sometime in intramural hematoma, particularly if you have a FMD causing a spontaneous coronary artery dissection, is something which is, but it can be life-threatening. I mean, it can just kill the patient. If patient develops acute VF because of acute ischemia, patient can develop primary VF and die. So this is case which I just wanted to discuss with you, that how do you decide? Do you image all those patients who present young with the cardiac arrest, or, for some reason, particularly female patient, postpartum?
Yeah, it's just on a case-by-case basis. As I said earlier, you have to be very cautious about instrumenting a vessel that's clearly dissected. If it's very obvious on angiography, I don't believe there's any additional benefit to be gained. If you've decided and made the diagnosis that it's a spontaneous coronary artery dissection by angiography, and you're going to manage conservatively, I don't think imaging adds anything further and may in fact cause harm.
Without imaging, you cannot make diagnosis, because how will you say that there is intramural hematoma without imaging?
That's different. I'm saying that if there is a scenario where the diagnosis is clear, if the diagnosis is in doubt, like in your case, then it may be reasonable cautiously to advance the catheter if you think there may be an associated dissection. Now, the other point I'll make is that we see from time to time, especially in the CTO world, this intramural hematoma. The other thing that you can do is to take a cutting balloon.
That's what.
You take a cutting balloon and release the hematoma. And sometimes, in certain cases, the compression of the lumen is so significant that you can't manage conservatively. And in many of those cases, we will just do a cutting balloon, release the hematoma, and then allow the vessel to heal, and not necessarily treat with stent. So that's another thing. And then my last point.
But in CTO, you on the table itself, you drain the hematoma by going into the hematoma and drain.
So if you're in the subintimal space and you're trying to re-enter, then yes, you may aspirate the hematoma in the subintimal space. Correct. Or there are situations where you might need to use a cutting balloon to release the hematoma. But going back to the imaging point and the point you made about Illumian 4, certainly Illumian 4 will add to the data that we have, and will further solidify, optimization and so on. But I would propose or submit to you that, we already have over 10 randomized controlled trials that are already telling us that imaging is better. In my mind, the question has already been answered, that imaging-guided PCI is superior to angiography-guided PCI. So for me personally, although I'm interested, curious, and excited to see the Illumian 4 results, it will only further enhance my sort of imaging and may give us more insight into how to optimize. but it doesn't add anything to, I believe, the established point that we should be imaging.
There is
Now,
one Dr. Yadav. Okay. Oh.
Yes.
Yeah,
Go ahead.
complete.
No, go ahead.
There's one Dr. Yadav from Delhi.
Yes.
He also asked a question that Illumine 3 trial recently presented showed no benefit IVUS, OCT, or angiography guided PCI. No benefit at all, no outcome benefit. How do you look at this?
Yeah,
so that we already discussed.
Yeah, I'm not sure. You know, all of these, you know, there's a lot of data, some of which may be discrepant, right? You've even suggested that there was a Japanese study that showed no difference. See, all of these studies.
I was saying about element 3 only. What I was talking to you about no difference is element 3.
Yeah.
It's recently presented in PCR.
Right, but all of these trials, like, I personally think that are effectively superseded by the more pure randomized control trials that are much larger scale, right? So ultimately,
the largest trial, randomized control trial at a large scale.
Right, but the largest trial that we have to date is Ultimate, and the largest randomized trial that we have to date is Ultimate, which showed clear benefit. Right, 2.9% of patients in the IVUS group had had the primary endpoint versus 5.4, almost 6% in the angiography guided group. And so, you know, I think it's important. We're always looking for whatever our own individual biases may be. We're looking for data to support what our bias might be. Right. So I would propose that, like, let's first assume cost is no option, assume, you know, and I understand that, you know, there are limitations, and it's okay to say, look, imaging is the right thing to do. I may not be able to do it for reasons X, Y, and Z, but this is the right thing to do for our patients. And, you know, so this should be done. So I think you'll have one trial here or there that shows otherwise. But the preponderance, if you combine all in a meta-analysis, if you look at the meta-analysis of all the trials, it still favors imaging. So based on that, you know,
element 3 trial was also powered very well to conclude whether optimization, intravascular imaging optimization versus angiographic optimization, or PCI guided by intravascular imaging or angiography guided PCI, both outcome were identical, no outcome benefit. Therefore, this also was powered to, you know, have a practice impact or game changer.
Yeah, I mean, but again, it's a much smaller trial than the larger trials that we've seen. I mean, it was only 400 or so patients in each arm. So it's a much smaller trial. But, you know, there are certain limitations with the trial too that, you know, but regardless, I think we all are agreed on the point of imaging in general and its role and importance. So that's, I think, the messaging that we're trying to sort of promote.
Correct. So great having you. And we had a very nice CME. I'm sure the case that Dr. Daggubati showed was an extraordinary left main aneurysm. I never seen that, you know, that patient, they again came back with a closed left main. They tried to wire it and all those things after the bypass surgery. Very unique case, and I've never seen such a case. But it was a Kawasaki disease causing aneurysm of the left main and RCA. RCA was hugely aneurysmal. It's the same patient. So very unusual cases that we have seen, and your case that 2 smaller stent was deployed and came back. That was also looked like a stent failure, but instead it was an inappropriate size stent. I think an excellent discussion we have.
Very nice. No, very enjoyable. I hope
very enjoyable.
I hope all the participants, you know, all over India and wherever else enjoyed it too.
There are some questions being asked, and let me ask you. I was in 5 to 10%. Why so low in Western world you quoted na, that almost 5.7% is the intravascular imaging being done in number of PCI that are done in America.
Yes. No, it's a good question. So I guess the question is asking, why is the adoption of intracoronary imaging so low?
Question is asked by Dr. Jagdish Sharma.
Yeah, no, Dr. Sharma, very good question. I think it's a combination of the same issues that you may be seeing in India as well. So it's a case of cost. It's issue of time. It's an issue of physician education. There are many physicians who during their training were not trained to use intracoronary imaging and so are not comfortable with the image interpretation. And then combined with that, as I alluded to in my talk, the other problem is that our societal guidelines have not been updated to reflect the newer data for imaging.
2011 guidelines last updated were 2011. So now almost 9 years passed by.
Correct. And a lot of data has come since then. And so on. And then again, so there's no one sort of looking over your shoulder to see, are you doing imaging or not, right? It's not.
I think guidelines are awaiting element 4 results.
In part. I mean, the guidelines are actually being updated right now. So the new guidelines are going to be published even before Illumin 4 are. We see the results.
Yeah. Okay.
But
you are part of the council. ACC council.
Correct. Yeah. So
even Perwaiz is there on the ACC council with you.
That's right. Yes. Yeah. So but there are a number of. So I think these are the things that we can do. If the question is, the initial question is, why is imaging use so low? The sort of follow-on question is, what can we do to improve imaging use? And I think there are probably 5 things. One is, as I've mentioned, to improve physician education, improve their interpretation of imaging, update the guidelines, maybe make them quality metrics, and then finally consider improving reimbursement.
Absolutely. The only issue with us in India that most centers have only 40 megahertz machine without any co-registration or 3D in the IVUS machine. So problem is that sometimes you get a great difficulty. Learning curve is a little higher, particularly proper interpretation. That is one. Second, many times you can't see clearly EEL because somehow the other 40 megahertz, the clarity of picture is not that good to give you clearly the, show you media and you can take a call where the EEL. It's not only that in calcified artery, you don't see EEL clearly, but in other arteries also, you don't see EEL that clearly.
Yes. No, it's not easy. It's not easy. OCT is much better at understanding.
Much better. Yes.
Yeah. And if EEL, I think is a construct that has come from sort of OCT imaging basically. And so I don't sort of try and look for the EEL with IVUS.
Correct.
Yeah.
You take an internal
luminal area. Yeah.
Yeah. That's the software gives the details about how much is the percentage of narrowing.
Correct.
All you have to do is just put a grid inside and that's it. The result automatically comes with the software. Excellent discussion we have.
Great. Thank you very much for the invitation.
Great talk. Nice having you. And your presentation was great. And other speakers also have had very great presentation. And we all enjoyed. Thank you very much. If anything, I'll let you know in the future so that we can come together and do this. Corona time, this is the best part, positive part of Corona is that we have this online education available.
Yes. Thank you very much for organizing and thank you for the invitation.
Thank you very much. Thank you. Great having you.
Thank you. Bye-bye.
Bye-bye.